Hello, everyone. My name is Lauren Flowers, and I will be presenting my capstone presentation on Project Elevate. New Hope Medical Center has decided to implement an electronic health record in order to rectify the issues discovered by the Joint Commission during its routine site audit. The vendor selected to implement this EHR technology is Oracle Health. The client has tasked my consulting firm in assisting with gathering the necessary requirements needed for the implementation and presenting the findings to ensure that the new EHR meets the mandatory requirements for certification guidelines. For the 8 weeks provided, the main objective was to complete an IT systems architecture proposal to present to the client stakeholders that incorporated research on EHR implementation processes, interviews with EHR consultants, and actual IT staff for hospital organizations that have gone through the implementation process. The key findings from this audit are failures highlighted in critical weaknesses, including documentation accuracy, below average ED wait times, medication reconciliation, and timely provider notes. Project scope. The total budget for this project is estimated to cost $30 million. This is the cost for the actual installation, also known as year one cost. Oracle Health clients pay a yearly maintenance fee to maintain and optimize the system as needed. The duration is set for 18 to 24 months. The total scope of this project is to complete Oracle Health EHR system implementation, upgrade all PCs and network infrastructure, integration of medical devices across the hospital with 300 inpatient beds and 25 outpatient clinics, training, support, and change management. This endeavor includes licenses, installation, training, infrastructure upgrades, and post-go live support. The allocation provides excellent usability, compliance with healthcare IT standards, better clinical operations, and future scalability, all while remaining within the $30 million budget. Analysis and decomposition. In order to efficiently capture and share patient data, healthcare providers need certified electronic health record technology that stores data in a structured format. These components fall into 6 categories. Data management. Under data management includes data capture and management for ease of retrieval and analysis of patient information. Free text in order to record clinical notes and narrative material. And quality. EHRs need to guarantee that the data entered is accurate, comprehensive, and consistent. Next is clinical processes. Under clinical processes are computerized provider order entries. This allows providers to electronically order prescriptions, lab tests, and imaging investigations. Clinical decision support provides alerts, reminders, and recommendations. Result management effectively handle and show laboratory and imaging results. And medication management. Medication management keeps track of patients' medications, allergies, and interactions. Care coordination. Under care coordination, there is interoperability, making it possible for various healthcare organizations and providers to exchange patient data easily, and tools for coordination. Promotes cooperation and communication amongst medical specialists. Patient engagement. Under patient engagement is access to patient portal functionality. This gives the patients safe access to their medical records so they can consult with clinicians, make appointments, and examine records. And patient education provides patients with information to assist them and their ailments and their course of treatment. Reporting and administration. Under this is billing and coding, assists with the precise and effective coding and billing procedures, and analytics and reporting. This offers resources for data analysts, analytics, and reports generated for public health and quality improvement initiatives. Last but not least is privacy and security. Under this is security, which safeguards patient information during transmission and storage. Access restrictions, which established role-based access restrictions to guarantee that only authorized individuals can view sensitive data. And audit logs. This keeps a record of all interactions with and changes made to patient information. Data source and data flow diagram. Another method I incorporated into this project was the use of a data source and data flow diagram to visually break down how the data flows and needs to be processed within the new data flow diagram. Under user interface, this will include registration scheduling, provider dashboard, and nurse dashboard. Next is input processing and validation. Following is data storage layer. Next is data cleansing. After cleansing is data analysis. We will be doing predictive analytics, remission risks and alerts, and dashboard visualizations. With the output layer being patient clinical summary, patient process reports, and research database. Additional methodologies. From the perspective of an IT consultant, my project focuses on providing assessments of the existing IT infrastructure, project budget, and overall system analysis to present to the stakeholders. The following assessments were completed as they were essential in providing critical information, not only to the project team, but the stakeholders as well. These include ethical, risk, and safety assessment, technical requirements assessment, financial assessment and budget proposal, and information systems architecture proposal. My key findings throughout this project: when conducting interviews with consultants in the healthcare IT/EHR sector, as well as the IT staff that was gracious enough to work with me, I discovered the following. Complex change management is required. Significant workflow redesign is necessary. Clinical staff often needs substantial training and ongoing support. And resistance to change is common, especially with physicians. Data migration changes. Legacy data conversions can be complex and time-consuming. And mapping and standardization across departments requires careful planning. Interoperability can be limited at first. While Oracle Health supports standards like HL7 and FHIR, integration with external systems such as lab, imaging, and billing may still face hurdles. And real-time data exchange isn't always seamless initially. High initial cost and resource burden. The implementation costs are significant, both financial and human capital. The ROI is typically long-term rather than immediate. And lastly, vendor partnership is critical. Ongoing communication and collaboration with Oracle Health representatives influences success, and tailored configurations are often necessary, not just out-of-the-box solutions. Challenges and interesting experiences. The hardest part of this project was ensuring that all aspects of the EHR implementation process was captured within system architecture proposal and project plans. The interesting experiences, those were the interviews I conducted to assist with the development of my project plan and architecture proposal exposed interesting tidbits. Those are: implementation timelines are often underestimated. Full EHR implementations can take 12 to 24 months, or even longer, depending on the size and complexity of the organization. Go lives is just the beginning. Optimization can take years. Physician burnout may increase temporarily. EHRs are often cited as contributing to physician burnout, especially in the first year. And providers spend up to 50% of their workday on EHR tasks, including after-hours work. EHRs can improve outcomes, but not automatically. Clinical outcomes improve when EHRs are efficiently configured, especially with decision support tools and protocols, as well as EHRs alone don't improve care. Workflow alignment and user engagement are essential. Cybersecurity being a bigger concern. Healthcare records are a top target for hackers, worth more on the black market than credit card numbers. And EHR implementations must include robust data security and privacy planning. Now that the initial proposal has been completed, the next steps within the project would be the start of the implementation phases. This process will normally take 18 to 24 months once the project scopes have been agreed upon, but as stated previously, can fluctuate depending on the scope creep, budget issues, and other unforeseen challenges. Other conclusions I drew from this experience include the following. Analyst is critical to the success of EHR implementation, in addition to proper budgeting and project planning. Failure to analyze current state operations as well as technical requirements can lead to preventable challenges in the future. And healthcare IT is consistently evolving. Every year, Joint Commissions, Centers for Medicine and Medicaid Services are updating requirements for EHR vendors. As a result, vendors as well as clients are in a constant cycle of change to obtain and maintain the certified EHR status.